Hello, everyone. I'm Anthony Gonzalez, the program coordinator here at the Higher Education Center for Alcohol and Drug Misuse Prevention and Recovery. I want to thank you all for joining us today as we kick off the first session of our free spring webinar series. But before we get started, we have a few housekeeping slides we'd like to go over. We have recently switched to Zoom as our broadcasting platform. We are excited about this switch and believe this will provide a better user experience. If I can direct your attention to the bottom of your screen, this is where you'll be able to submit your questions for our presenter. We welcome all of your questions and please feel free to submit them anytime throughout the session. We will field the received questions to our presenters at the very end. We also encourage you to learn more about becoming a member of the Higher Education Center, which includes access to our ScreenU program. ScreenU is a web-based screening and brief intervention referral to treatment program. We have recently launched a new demo of the program, so we encourage you to take a look. You can do so by searching go.osu.edu/ScreenU demo for access. And of course, you can learn more about the benefits of becoming a member by visiting our website at hecaod.osu.edu. And with that, it is my great pleasure to introduce to you our presenters for today. Joining us, we have Dr. Brandon Marshall, Associate Professor of Epidemiology at Brown University School of Public Health, and his colleague Diego Arene-Morley, Community Engagement Coordinator at RICARES. Thank you both for joining us today, and it's my pleasure turning it over to you now at this time.
Great, thanks so much, Anthony. Can you hear me okay?
Yeah, you sound good.
Great. Thanks everyone for joining. We've got about 40 minutes of material and hopefully that can save the rest of the time for questions. In terms of my presentation today, there are 3 objectives. I wanted to start by reviewing very briefly the state of harm reduction programs in the United States and define a little bit about what harm reduction is. And then we're going to focus most of our talk today on the role of drug checking as an evidence-based intervention and part of a comprehensive harm reduction programming to reduce overdose deaths. I'll then finish by talking about the results of a recent pilot study we conducted, looking at the feasibility and acceptability of fentanyl test strip distribution here in Rhode Island. I'm going to then turn it over to Diego, who's been leading some campus-based efforts to integrate drug checking, particularly involving fentanyl, in 3 campuses, college campuses here in Rhode Island. Oh, Anthony, I think it bumped me out. Oh,
yep, just start from current slide, perfect.
Thanks. Great, so just to orient all of us, this is a definition of harm reduction from Harm Reduction International that defines harm reduction as policies, programs, or practices that aim to reduce the health, social, and economic consequences of the use of both legal and illegal psychoactive drugs. I would add here the additional clause that this doesn't necessarily require abstinence from drugs altogether to achieve these aims. Diego is going to deepen this definition a little bit more for us later and talk about how harm reduction and recovery can work together. There's a couple of principles that harm reduction typically abides by in most countries, including the United States. The first is that it's based on a strong commitment to public health and human rights and centers the rights of individuals and people who use drugs at the center of its practice. The second is that it's meant to be practical, pragmatic, and feasible. So we think about how we can practically design harm reduction programs to be implemented in communities. The third is that it's evidence-based. There is research supporting harm reduction programming. And the additional thing here to think about is that if research or evidence shows that a specific program or practice doesn't work or causes harm, a principle of harm reduction is that we would not pursue that approach, rather rely on programs that do have scientific evidence supporting them. In the vast majority of cases, harm reduction programs are cost effective. Often they can even be cost savings, particularly when you think of the cost associated with treating lifelong infections such as HIV and hepatitis C. And then finally, harm reduction is incremental. The idea is that we focus on any positive change as being an outcome we wish to see in individuals. And so focused on meeting people where they're at is another way to think about this principle of harm reduction. Moving folks incrementally along a process or a continuum, I should say, of drug use, problematic drug use, to any positive point is better from a population health perspective than insisting on, say, one final endpoint, which may or may not be abstinence for some people. In terms of the state of harm reduction nationally, I just wanted to talk a little bit about what that looks like using syringe service programs as an example. This is one example of harm reduction programs that are endorsed by the CDC. This is the definition of syringe service programs put forward by that agency. You'll see that SSPs, as they're called, provide a range of services, including the access to sterile syringes and injection equipment to prevent the transmission of infectious diseases, but they're also, many cases, providing many other services, including linkage to substance use disorder treatment, other injection supplies, HIV and HCV testing, and so forth. I think nationally, however, even when it comes to a program that is endorsed by a federal agency like the CDC, we still have a long ways to go. This is from a report from AMFAR. This is maybe a little bit old. Hopefully we've seen some more progress since the 2017. But this map shows you that there are still 15 states in the United States as of 2017 where SSPs were actually illegal at a state level. There are other states such as Pennsylvania where they may be locally permitted through local laws or regulations, but not necessarily fully supported by statewide legislation. The report also looked at counties and those that are particularly vulnerable to outbreaks of HIV and hepatitis C among people who inject drugs. This was based on a report that the CDC produced in 2017 coming out of the outbreak of HIV in Scott County, Indiana. They did an analysis and found 220 countries across the US that had similar characteristics to Scott County and therefore may be at risk for large outbreaks of these infectious diseases. And what this report found was that of those 220, 93%, 205, didn't have an operational SSP. So we certainly have a long way to go in terms of the national picture of harm reduction in this country. So I wanted to focus on fentanyl in the rest of the talk. This is a major issue here in Rhode Island and other states, particularly in the Eastern Seaboard and also in places like Ohio. Fentanyl is a potent synthetic opioid. This image has been widely distributed. It shows 3 milligrams of fentanyl, which in some people can be a lethal dose compared to what can be a lethal dose of heroin, which is about 30 milligrams. It's used in the medical environment, particularly in anesthesia. What we'll be talking about today is illegally manufactured fentanyl, which is increasingly contaminating the illicit opioid supply here in Rhode Island and in other cases, other places across the US. Even nationally, fentanyl has emerged as a major driver of overdose mortality. This figure shows you overdose mortality rates in the United States over the past almost 2 decades. And what you can see in that dark blue line is that fentanyl is now actually accounting for the majority of opioid-related overdose deaths in this country. CDC doesn't break down fentanyl-specific overdose deaths, but the vast majority of that class, synthetic opioids other than methadone, are due to fentanyl. But you can still see we have increasing and high rates of overdose deaths from other opioids, natural and semi-synthetics, prescription opioids, and heroin as well. But we're going to focus today on fentanyl and some things we can do to mitigate exposure and harm to that substance. These are some data from Rhode Island, which show you the rise in fentanyl-involved overdose deaths over time. The number and proportion of overdose deaths due to fentanyl or related analogs in Rhode Island is shown in yellow. And you can see that in 2018, over 70% of all of our overdose deaths in the state involved a fentanyl or a related analog. And preliminary 2019 figures show that that proportion has stabilized. It's not going down. Another way to look at these data is to think about what our situation would be in Rhode Island if we had not seen the emergence of fentanyl. This just shows you the number of overdose deaths in Rhode Island that are not due to fentanyl. And you can see that those have actually come down quite a bit over time since the peak in 2013. So fentanyl now is a predominant driver of overdose mortality in Rhode Island. I wanted to talk a little bit about the research we've done to understand the landscape of what fentanyl exposure looks like among people who use drugs. And this was one study we published that was a qualitative study back in 2017, where we talked to folks who were using opioids about their perspectives around being exposed to, at that point, predominantly fentanyl-contaminated heroin. Fentanyl now has been found in pressed pills, counterfeit opioids, benzos, and to some degree, there's some evidence that fentanyl contaminates stimulants such as crack and methamphetamine as well. So I won't go into a great deal. If you're interested in the paper, we can certainly pass it along to you, but the first author had a nice summary of the major findings. I think she spoke to over 50 people who were using heroin or other illicit opioids. These were some of the main themes that emerged from that paper. The first was that in our setting, there were predominantly negative perceptions of fentanyl. Many people felt that they had been exposed to it and that the experience was negative. Fentanyl causes a very rapid onset. It has a strong sedative effect, a sedative effect, which is why it's used in anesthesia. So many people reported not actually liking that feeling. The second was that people overwhelmingly understood the dangers associated with being exposed to fentanyl. Many participants had friends or people they knew die of a fentanyl overdose. Rhode Island was one of the first states that started reporting fentanyl overdoses. We found that it's well known in the community that fentanyl is a problem and is a driver of overdose deaths in our state. People engaged in different risk strategy to mitigate their exposure to fentanyl. Some people talked about working or knowing with your dealer to try to understand what the individual is purchasing. So that was, in the absence of other harm reduction programs, one technique folks were using to try to reduce the risk of fentanyl, which was having a consistent or known supply. And fourth, many people reported trying to seek medication treatment, buprenorphine or methadone, as a result of either overdosing on fentanyl or knowing someone who overdosed on fentanyl, and then reporting many challenges associated with trying to access treatment around insurance, physicians not accepting new patients, and so forth. So that was a surprising finding to us, actually, and has prompted a lot of improvements in the treatment system here in Rhode Island to try to address some of these challenges. So I want to move down to the focus of the webinar, which is on drug checking programs. I first found out about these programs from colleagues in Canada who had started to implement these programs in pilot capacities at supervised consumption facilities, in about 2016, 2017. One technology they had been using were fentanyl test strips, which is what we're going to focus on today. So there are some photos there that show you what they look like. And they detect fentanyl or analogs in urine. That's what they're actually designed for. But since urine is mostly water, they're also effective at identifying even small amounts of fentanyl dissolved in water. They are now being distributed by harm reduction organizations throughout the United States. Many states, including our own, now have laws that protect individuals who are distributing or using fentanyl test strips, which Diego can also talk about. At this point in 2017, however, there had been a lack of research on uptake and acceptability of fentanyl test strips, particularly around young people. And so that's what my team sought to answer with a pilot study we conducted in 2017, 2018. So we did have some concerns when we were launching this pilot, which we sought to address. The first was, as I mentioned, these tests were designed to be used forensically to detect fentanyl residue in urine samples. So there was some uncertainty at that time as to whether they would be effective at detecting fentanyl in water. We know now from some other work that that answer is yes. They are very good. They're very sensitive to even minuscule amounts of fentanyl and many other analogs. The results are, we were concerned about whether the results would be difficult to interpret. They're generally pretty easy, with the one caveat that 2 lines means that they're negative for fentanyl, 1 line means that it's positive. And so that can be confusing. We actually show visually how to interpret the test on a label that we affix to every package to make sure that folks don't confuse how to interpret them. There's a lot of people that are concerned about false negatives. As I mentioned, other studies have shown that these strips are very good at detecting fentanyl in most of the analogs that are circulating in the illicit drug supply. That being said, they may not pick up everything. There are many other contaminants that can be dangerous or that can put folks at risk for overdose. So we still have a message out there of, being careful and engaging in harm reduction practices, regardless of what the result is. But the idea is that this provides some additional information that people may find useful. And the final 2 things are what our pilot studies sought to answer. Will young people use them? And will they promote engagement in harm reduction practices and reduce overdose risks? So that's what we focused our study on. So just to go into a little bit of the details for you, we recruited almost 100 individuals who were 18 to 35, who are currently living in Rhode Island, and had used any number of illicit drugs where we are concerned that there may be contamination with fentanyl, predominantly heroin, but as I mentioned, some stimulants and pills purchased on the street in the past 30 days. At that point, we were still concerned about this urine testing issue. So in the pilot, we actually had 2 arms. In one arm, we actually did ask people to test their urine, sort of as a confirmatory arm, if you will. In the second arm, we asked people to test their drugs dissolved in a little bit of water before use, and we trained them how to do so using controls. That was really the only difference between the 2 arms. Both received training on how to do this and were given 10 test strips for personal use at home. We did not test any samples on site. We showed people how to use them and said, use them when you feel that you may be at risk. And then after 2 to 4 weeks, we brought them back for a follow-up interview combined with a qualitative survey. So in terms of the first visit, just to give you an idea of who we enrolled, the mean age was 27. We had a fairly diverse sample that generally represents the population of people using drugs in Rhode Island. Just over half were male, 40% female, and 4% identified as another gender identity. The same, approximately just over half were white, 15% were Black, a fair number identified as being of mixed ethnicity or race, and 24% identified as being of Latinx ethnicity, which is fairly representative of the population in Rhode Island. We recruited a fairly diverse group of people who were using. We designed the eligibility criteria to be broad. We certainly had some students who were enrolled in the study who used drugs fairly occasionally on the weekends. And then we had other folks who were injecting, who used daily. Over about a third had reported a prior overdose, and 2/3 had ever witnessed an overdose. So a fairly high risk sample, but a lot of variation also in the types of drugs used and the risks associated with that. At baseline, people overwhelmingly said they planned to use the strips, and essentially 100% said that it'd be easy to use them after the training that we provided. A couple of other baseline data points which I thought would be interesting. Around 70% were concerned about their drugs being contaminated with fentanyl, again reflecting that people are concerned about it generally, at least here in Rhode Island. There was really mixed opinions as to whether people could identify fentanyl mixed in with other drugs. Some people felt that that was false, others didn't know. Some people felt that were true. So again, showing a little bit of uncertainty into how well you can identify fentanyl visually. The answer is it's very difficult because such a small amount of fentanyl can cause an overdose. So that's again where these tests are important. It can be very challenging to identify fentanyl contaminated drugs visually before consumption because of that reason. Nonetheless, the vast majority again said that they would like to know that there was fentanyl in their drugs before they used them. A couple of results from the follow-up visit, which we published recently in International Journal of Drug Policy. Around half reported, let me reorient myself. Okay, yes, 87% returned for a second visit of the 93 were recruited. Of those, 77% reported using at least one strip. When we asked people why they didn't use them, many actually said, well, I don't use that drugs that often. If you had talked to me in 2 weeks or later, I might have used them. I just didn't have the opportunity to use them. So in hindsight, I wish we had had a longer follow-up period, a learning lesson for me. And of those who reported using one strip, 50% reported getting at least one positive result, again showing the extent of fentanyl contamination in the illicit, particularly opioid supply here in Rhode Island. We asked people what they did after they got a positive result, and we didn't do a lot of training on this. This is a pilot study. We wanted to look at feasibility and acceptability of using the tests, and we presented folks with a menu of harm reduction behaviors that we felt would be good to engage in after getting a positive. And indeed, people reported a number of different behaviors. They used smaller amounts, they went slower, they used with someone else around, they did what's called a tester shot if they were injecting, where you use a little bit of a amount, not the whole thing. 10% actually reported throwing their drugs out entirely, which somewhat surprised us. In a larger study we're doing now, we're refining some of this training to focus on having naloxone nearby and using with someone else around. Using smaller amounts isn't necessarily the best practice, given again that such a small amount of fentanyl can cause an overdose, particularly in folks who are opioid intolerant or naive. Overall, 2/3 of people, 68% reported some positive change in overdose risk reduction practices compared to what they reported doing at baseline before the training. Thus showing that I think convincingly, at least in this small pilot population, that fentanyl test strips have an important role to play in promoting overdose risk reduction behavior. So I wanted to finish with a couple of other points that might be interesting, and I'll hand it over to Diego. At the follow-up visit, the vast majority reported liking the strips. They wanted to continue to use them. You can see the proportions there. We also asked people where they'd like to get them. A whole wide variety of places were identified: pharmacies, community-based organizations, community health clinics, and so forth. So we thought that was interesting as well. We did do a qualitative study, and I think these are very compelling and powerful for people to think about at an individual level, the types of behaviors that we saw as a result of fentanyl testing. So this individual who's 20 years old said, fentanyl is going to show up in the test, so it's worth it. What I'm saying is you could save your life by doing this, or you could not use it and you could be dead. I thought it came up positive, so I got rid of the fentanyl. This person who's 28 years old said, everything about the tests was useful. The tests opened my eyes. I think it saved my life. I can gladly say I haven't taken any more because I was going to take 2 bags. If I had taken those 2 bags, he's referring to heroin, I think I wasn't even going to be here right now. So again, people understanding the risks of fentanyl and understanding that this is an important way to reduce the risk of fentanyl overdose. And then this one I thought was interesting, age 22. I would say we were definitely a lot more cautious about what we were doing. This person was using the fentanyl test strips as part of a group. Definitely a lot more ready to act. I definitely would pace myself a lot slower. And if it was like I said, it's kind of sad to say, but we were almost expecting an overdose. And so if that did happen, at least somebody could be, and jump on and act fast. This is important because fentanyl overdoses happen very rapidly. The symptomatology is very fast and severe. So folks that are around need to act quickly and call 911 and reach out to medical services. And so this is an interesting way to think about, even if the fentanyl test strips aren't causing someone to not use or to have naloxone nearby, even if they choose to use, there may still be benefits in other ways in terms of encouraging folks to call 911 and to administer naloxone promptly. So that's essentially all I have. I would just finish by saying, in part due to the research and a bunch of fantastic advocacy led by folks like Diego, we were able to pass a bill in Rhode Island legalizing fentanyl test strip distribution, and they are now being distributed by a state level, including by RICARES, which we'll hear about, and by other organizations. This is an example of a community event we had where fentanyl test strips are being distributed as part of other harm reduction programming, naloxone distribution and training, for example. And there's one of the kits that's distributed. I've also mentioned we have a website here in the state, preventoverdoseRI.org, where you can obtain a lot of information and resources on fentanyl testing and fentanyl generally. The link here will take you to a fentanyl test strip specific page with some infographics and some of the training materials that we used in our study. There are other organizations that have produced similar materials as well that you can find online. I wanted to throw this up there in case this is helpful. So with that, I'm going to wrap up and turn it over to Diego. I just wanted to thank all of the participants for their time and contributions to the project, and my wonderful staff and students really do the work. The pilot funding was funded by Brown, actually, and we do have a larger study, as I mentioned, which is funded by the National Institute on Drug Abuse, which is just launching. And you can feel free to reach out to me if you have any questions around the study or what I presented. So with that, I'm going to pass it over to Diego, and I think we're going to go right into that, and then we'll have time for questions at the end.
Okay, great. Thank you, Dr. Marshall. Very cool. So my name's Diego. I am a certified peer recovery specialist with RICARES, which stands for Rhode Island Communities for Addiction Recovery Efforts. You can check us out at ricares.org to learn about some of our programming. So my three objectives are going to kind of build off some of the groundwork that I think Dr. Marshall laid out. One is reconceptualize harm reduction as a recovery pathway. This may seem a little interesting or controversial to some of us because we generally assume that harm reduction and recovery are kind of at odds with one another somehow. And I think they actually are way more overlapping. So that's going to be the first kind of key objective. Second one is going to be to outline 3 different approaches to fentanyl test strips on 3 different college campuses in Rhode Island. And then 3, I will provide some links to the relevant documents that might inspire other campuses interested in moving forward. Okay, so starting, here's kind of a fun little exercise. The SAMHSA definition of recovery, the federal government's definition of recovery, which I think is a pretty good one, is a process of change through which individuals improve their health and wellness, live a self-directed life, and strive to reach their full potential. The harm reduction definition, and this is just one, is any positive change. That is from the Chicago Harm Reduction Alliance. And if you just study those 2 wordings, and believe me, they spend a lot of time on the wording, there are actually a lot of similarities. Both are incremental. That was something Dr. Marshall touched on. Process-oriented, and they hinge on individual agency, not abstinence necessarily. The SAMHSA definition doesn't talk about drugs at all. That's actually not really the point. The point is way more on this agency and individual agency. And I think that is at the heart of what the harm reduction and recovery communities share. They're kind of just 2 different frameworks with lots of overlap. I wouldn't say they're the same thing. I wouldn't really say they're very different things. They're just 2 different languages that overlap. So, for example, harm reduction as recovery. I think on campus, something very common, and this is something that we see talking with students, is single substance abstinence is a common recovery goal on college campuses. So students may be seeking to refrain from using cannabis after experiencing lots of problematic use. They wake up and they consume cannabis and they have this problematic habit that they would like to change. But this person might still engage in non-problematic use of hallucinogens. this person might have a beer on the weekend. So this person has a recovery goal. It's not our typical version of abstinence. So this person actually would be a really good candidate for using fentanyl test strips for their experimental use. So they're both achieving a recovery goal and engaging in harm reduction simultaneously. So why campuses? Here I kind of dug down into some of the amazing data that Dr. Marshall's team has worked on, all available at preventoverdoseri.org. So in 2015, we look at fentanyl-related overdoses by age group, and we see 18 to 24 are about 50% of them are fentanyl-related, and the age group of 25 to 34 is actually more likely to experience a fentanyl-related overdose. This changed very rapidly in 2 years. This is 2017. In 2 years, almost all of the overdoses for the 18 to 24 age group were fentanyl related, except for one. So it went from 50% to 94% in 2017. What this says to me is that the younger consumers of drugs who may be problem consumers or experimental consumers or somewhere along that continuum are encountering fentanyl. And here's the key for, I think, campuses. They are at particular risk because they do not expect to be encountering an opiate. They're expecting to be encountering things like cocaine, benzodiazepines, Xanax, and things like MDMA or other amphetamines. So these are not necessarily people with a substance use disorder, and they're not necessarily people who have ever consumed an opiate before, which puts them at a unique risk. And they decide once a year at a music festival that they're going to take something with their friends, and that thing has a very small amount of fentanyl in it, which kind of puts them in a very risky and dangerous position, especially kind of how Dr. Marshall was talking about. Part of the intervention, even if they use the strip or not, is simply being aware of the risk of opiate overdose for consumers of non-opioid drugs. That, I think, is a huge one, that they know what naloxone is, that they know to call 911, they know to recognize the signs of an overdose so that they can get someone help who maybe they thought only was doing cocaine and drinking some alcohol, so they just assume, well, they'll sleep it off and they'll be fine. That's the kind of thing that keeps me up at night. So we engaged. Rhode Island is very small, so we have the opportunity to engage campuses all over the state. There's an interesting mix of campuses. So the ones that we've really had success with are Brown University, Rhode Island College, University of Rhode Island, and Roger Williams University. All kind of different sizes, different flavors of school with different cultures. Those who have been more difficult to engage, Providence College, Bryant, RISD, and Johnson & Wales, also kind of mixed and different. So how did they engage? So Brown University has a chapter of Students for Sensible Drug Policy, which is a national organization focused on bringing harm reduction practices to college campuses. And they've been around for a long time. So they sought to purchase fentanyl test strips from RICARES. We make fentanyl test strip kits that we distribute with naloxone. They wanted to purchase for campus distribution with university funding. The Student Affairs Office, SAO, rejected their use of university funds due to the program allegedly violating the Student Code of Conduct. So this is actually from the email they sent us. So they said, thank you for submitting the proposal. The proposal was sent to the Office of General Counsel, Public Safety, all these other departments within the school, and they decided that no, this was not going to be something allowed on campus. When I reached out to them and said, well, can RICARES come and distribute just on campus to students that are interested? They said no, because it is illegal to possess illicit drugs on campus, and this is D3, knowingly or recklessly aiding, abetting, assisting, or attempting to aid or assist another individual to commit a violation of the code. So they're legal, and this is in the parentheses right after that, D3, they added, this piece applies even if SSDP isn't technically in possession of illegal substances. This interpretation of their student code of conduct, to me, almost categorically excludes all the harm reduction techniques that we know that are out there. Because if you say to someone, if you're gonna consume a drug, consume less, or you might think about consuming in this way because it is less likely to lead to this, that could, in theory, I guess, knowingly qualify as knowingly aiding and abetting, assisting, or attempting to assist an individual to commit in violation of the code. I happen to think that we're doing this in a way that's not recklessly aiding at all, but the opposite of recklessly aiding. But that being said, this is what we were told. So we're kind of at an impasse at this point. That's what it seemed like. So it is also worth noting that the university believes simultaneously that they engage in significant harm reduction efforts despite not allowing naloxone and fentanyl test strip distribution by students for students. So this was from another email. Brown absolutely has commitment to harm reduction and recovery efforts through such offices. Significant resources are dedicated in each area. The other schools you mentioned in your email also do not appear to be conducting drug testing on or around campus, as we attempted to research that last month and were unable to find any information that pointed in that direction. This is another interesting organizer's note. Every school will say, no one else is doing it, so we won't do it. That, of course, is a problem because then no one else will ever do it and be the first one. So we sort of have come to an impasse with Brown, but there was an interesting way forward. RICARES approached President Christina Paxson, who's the president of Brown University and a public health researcher herself, directly to update her on fentanyl-laced non-opioid drugs. Upon learning that a significant percentage of cocaine in Ohio, as well as now Rhode Island, contained fentanyl, President Paxson immediately understood the seriousness of the problem and the risk for experimental and potentially problematic users alike on campus. The president was also aware of the $1 million funding that was going to the Brown School of Public Health and Dr. Marshall's team for all of this innovative work they do in harm reduction and recovery. But the Student Activities Office was not. So these different departments on campus all actually kind of operate in a loose cohesiveness, and we were able to exploit some of that. So SSDP approached the Office of the President directly to coordinate a fentanyl test strip program with the Office of Student Wellness. SSDP clarified, and I think this was important, that they would not be testing drugs themselves, but distributing the test strips with clear instructions on how to test. I thought they had made that very clear before, but again, it is worth noting that piece was important to clarify for legal reasons, obviously. So we kind of sidestepped, and now the Office of the President and the Wellness Department are going to meet directly with us and Students for Sensible Drug Policy to potentially purchase and train fentanyl test strips. At some point, I'm assuming it's going to get back to the General Counsel and the risk management offices and things like that, but it will be in a very different place because of the backing of the Office of the President. I did not expect things to shake out that way, but they did. So here were my takeaways from Brown, and then I'll talk a little bit about some of the other schools. 1, establish the risk of fentanyl-laced drugs for problem and experimental substance consumers. So people, and this is a bigger takeaway for all of us, people with substance use disorder may be at risk of overdose, and people without substance use disorder may be at risk of overdose, and everyone in between. That was my first takeaway. And people really understood that, and President Paxson understood that. Second takeaway, work with any department or individual administrator who supports the work. This really varies campus to campus, and when you find a counselor, maybe a counselor in recovery who appreciates harm reduction and recovery work, run with them. Involve recovery organizations to combat the pro-drug misperception. This has been a problem for Students for Sensible Drug Policy on campuses for a long time, that they were viewed as the kids that do drugs or the kids that are pro-drug. And that is just totally not the case. Actually, there are plenty of students who live a sober life who are in Students for Sensible Drug Policy because they understand that if someone passes away, there is no opportunity for recovery. So that makes the fentanyl test strips totally a recovery-related and a recovery-oriented tool and a harm reduction tool. Last takeaway was involve as many campus organizations as possible. So Brown Students for Sensible Drug Policy wrote articles in the newspaper, distributed surveys. They worked with the Dean of we work with the Dean of Substance-Free Student Initiatives to support recovery, to kind of make this issue not just about, oh, those are the kids that like to use drugs. So that was the Brown experience, and which has taken an exciting turn in a different direction, which I'm excited about. So at other colleges, things went a little differently. So the first I'll talk about RIC, or Rhode Island College. So at Rhode Island College, Recovery, which is the student-led recovery group on campus, invited RICARES to apply for the Rhode Island College guest lecture series to do a presentation on the overdose epidemic in 2019, naloxone, fentanyl test strips, harm reduction, and recovery 101. So this was a very different approach because there is no Students for Sensible Drug Policy on Rhode Island College's campus. So it kind of went through different channels. Interestingly enough, senior administrators had previously said, long before this, that fentanyl test strips would, oh, and I'm sorry, there's a typo here, that fentanyl test strips would not be in line with the Student Code of Conduct. But the committee for the guest lecture series allowed us to bring them. So again, we're doing stuff that no one else has really ever done before, and you just gotta kind of find a way, even when it seems like there isn't one, and not exactly take no for an answer. Next, I'll talk a little bit about, and this should say University of Rhode Island, or URI, which is the biggest school, I think, in Rhode Island, state school. So they took sort of a different approach because a URI student had reached out to RICARES to connect with some administrators at URI on creating a SMART recovery meeting on campus. SMART, for those of you who don't know, is a non-12-step based recovery pathway that's focused more on cognitive behavioral therapy. SMART stands for self-management and recovery training. So this URI student in recovery wanted to bring a SMART meeting or get more involved in the recovery community on campus because URI's recovery student group had sort of fallen off after some of their leaders had graduated. And what we've decided and what we're working towards is that naloxone and fentanyl test strip distribution could happen at that SMART meeting as a way to attract more interest and to get people to start to engage around the substance use that's going on at their college, whether it's experimental, whether it's problematic, or somewhere in between. Again, with this age group of 18 to 22-year-olds, the substance use disorder diagnosis may not be super clear. There's a lot of life change, there's a lot of things in flux, which makes it a unique opportunity for recovery specialists to intervene. And again, they are intervening not with an abstinence-based framework, because abstinence is not necessarily recovery. They're intervening with that self-directed life approach, which is hinging on agency. That's the big one, agency. And lastly, we worked with Roger Williams University, which totally had a different approach, which is that we have been working with their health and wellness educators, who are students at the school, to distribute naloxone and fentanyl test strips. And so they have health and wellness educators on a variety of subjects. They have an alcohol and other drug team. And those students actually made contact with RICARES because they were interested in getting fentanyl test strips and distributing them. The director of health education at Roger Williams, who supervises the peer educators, has expressed a real interest and support for the fentanyl test strips in the program. We will proceed as if the administration supports the work and ask permission later on if it comes to that. So each school had slightly different trajectories. Some started with students, some started with a combination of administrators and students, different types of student group. So again, it kind of depends on campus to campus. So I made a quick recap at what happened at different places. And here I've included some links to check out what SSDP has put together, their drug checking proposal, our application to the guest lecture series at Rhode Island College, and then the Smart Recovery Flyer, which we're working on with the University of Rhode Island. Thank you, everyone, for your time.
Thank you both so much for sharing both of your hard work. At this time, we welcome any questions that participants might have. We actually have one right now for Dr. Marshall. It is wondering if you've studied the use of other forms of drug checking, like reagents or high-level technology, such as an FTIR, or and the use of that among non-opioid drug users.
That's an excellent question. Myself and my team, I focused on the fentanyl test strips, partly because I see them as feasible and scalable. You know, they're typically quite inexpensive. And again, people in the pilot express a lot of interest in them. Now, that being said, some of my colleagues are evaluating some of the other drug checking technologies, including FTIR. So that research is ongoing. And of course, the benefit of some of those technologies is that they identify lots of other contaminants, and they also provide information on the amount. The fentanyl test strips just give you a positive or negative. So some people may like to know more information on what's in the sample. So that's happening. I know that's going on in Boston, and I'm kind of eagerly awaiting the results of some of that research. These machines do typically tend to be quite expensive, on the orders of tens of thousands of dollars, which is one barrier for harm reduction organizations. I don't know if college campuses have been involved in this. I might turn that over to Diego.
Yes, so Brown Students for Sensible Drug Policy had been purchasing reagent kits from an organization called DanceSafe. And that was the program that Brown Students for Sensible Drug Policy, using university funding, basically would teach people how to test substances to make sure they were actually what they said they were. The university cut that program off just last year. And so part of moving forward with the fentanyl test strips has been to say, okay, wait a second. If you're gonna say you're interested in harm reduction, especially now in this time where just recently fentanyl has really made its way into everything, the fentanyl test strips have to be like the floor for all harm reduction efforts going forward, just because the risk of fatal overdose is so great. So it's one thing if you're testing MDMA to make sure it's MDMA and not a slightly different compound, which is important, but that slightly different compound is probably not going to kill you. The fentanyl, especially if you've never taken an opiate before, might just kill you.
Thank you. Thank you both for answering that. Can you speak to how expensive the fentanyl testing strips are?
So the fentanyl test strip distributor that we use for a variety of reasons is called BTNX, which is a Canadian company. We think that their product is the most accurate. The strips, you have to sort of buy them in bulk. The strips come out to about $1 per strip. We make fentanyl test strip kits that we distribute with naloxone, which contain 3 individual strips. They also contain 3 little aluminum caps so that you have a place to add water and dissolve a small amount of the drug into that cap. We add the sterile water into that kit as well so that someone can, with their substance, have everything they need to test. We include an infographic. We include connections to other recovery coaches as well. Those kits, which contain 3 strips, the water, and the aluminum cookers, are $4.99 a kit. So that is where we can basically break even and cover a little bit of the free strips that we give out when we do our street-based outreach. But pretty inexpensive compared to the drug checking machines, which are cool, but which are like $20,000+.
Perfect, thank you. And we just have one more question. Are fentanyl testing strips legal in Rhode Island? In California, any drug checking equipment is considered illegal paraphernalia. States' university funds cannot be used to purchase them, nor can they distribute them.
So yes, we explicitly included fentanyl test strips in the same language of the bill that protects naloxone use. So, which here we call the Good Samaritan law that protects someone who administers naloxone to someone else. The fentanyl test strips are similarly included in that bill. That was like, without that bill, we wouldn't be here today. And so that's got to kind of come first.
It's a very good question. You know, that was a bill that, as I mentioned briefly, had a lot of momentum from organizations such as RICARES, advocacy work, and it actually, I think, was passed unanimously by our House and Senate and signed by the governor on Overdose Awareness Day. So we had a lot of support for that bill. I think, going back to Diego's earlier point, people, at least in Rhode Island, understand the severity that fentanyl brings to the overdose crisis. And this is one thing we can do to help address that. So yeah, I think it was perceived as being a very sensible, straightforward amendment to the Good Samaritan law.
And I think connecting it with naloxone was the right logical step in terms of creating that favorable public perception. But I can see that passing a law like that could be a challenge in other states.
Mm-hmm.
We actually have one more question, if you have the time. Has there been any discussion in Rhode Island on safe drug supply, either in the form of heroin-assisted treatment like in Switzerland?
Yes, there has been. We are moving forward, kind of working closely. Again, Rhode Island is cool because it's so small that the people, recovery specialists and harm reduction specialists, work very closely with researchers. So we are putting together a bill that will require the Department of Health to provide a framework of regulations for a safe consumption space. Heroin will not be given to participants. It will be a bring your own drug of choice to the center and then use under sort of the supervision of a nurse with the opportunity to connect to treatment and recovery services. So a little different than some of the European models, but I think a step in the right direction.
In terms of the treatment aspect with heroin or heroin-assisted treatment programs, I don't think there has been a lot of discussion that I know in Rhode Island, so that's something that communities here could consider. From a research perspective, it's challenging because it is a Schedule I substance, so it's very challenging. Not impossible, but very challenging to, say, launch a research study, which is partly why, to my knowledge, there hasn't been a HAT study in the United States. There are other pilots in Vancouver that have looked at an injectable hydromorphone, for example. Those may be more feasible from a research perspective to get off the ground, but I don't know of any, and we haven't had those conversations yet. So here in Rhode Island, it's focused, as Diego was mentioning, on strengthening the harm reduction and recovery communities and scaling up the resources they need to do their work. Fentanyl test strips, I think we've had a lot of success with relative to other states particularly, and then discussions and proposed legalized legislation around supervised consumption as well. Yeah, good question.
Good question.
Well, thank you both so much for being with us today and sticking around to answer those questions. Just a reminder that this session's recording will be uploaded to our website and YouTube page within 3 business days. And of course, if you have any additional questions, please feel free to share them with us here at the center. I would also like to take this time to bring to your attention our upcoming national meeting, which we have each year. This year will be taking place August 4th through the 6th, happening at the Ohio State University campus in Columbus, Ohio. Early bird registration will be opening very soon. And here are some ways that you can stay connected with us here at the center. Thank you to all of you who have joined us today, and please stay tuned as our Spring Learning Collaborative will be announced early next month. Thank you all, and take care, everyone.